Hi there. Today, we'll explore a fundamental concept in pharmacology, the first pass effect, also known as first pass metabolism or pre-systemic metabolism. Differences in drug administration routes dramatically affect clinical outcomes. For example, a medication that is effective when given intravenously may become ineffective when taken as a tablet. Why does this happen? Before understanding the first pass effect, one must define bioavailability, F. It is the fraction of an administered dose of unchanged drug that reaches the systemic circulation. For intravenous administration, F equals 1 or 100%. To understand why, let's look at how oral drugs move through the body. The loss equation. Here's the key equation. Bioavailability, F, equals FA times Fg times FH, where Fa is the fraction absorbed from the gut, Fg is a fraction escaping metabolism in the gut wall, and FH is a fraction escaping metabolism in the liver. Bioavailability is explained in detail in our channel. Please watch it for more. The link is given in the description. Okay, friends, let's continue. Intravenous administration is the gold standard for 100% bioavailability because it bypasses all physiological barriers and metabolic checkpoints. For oral administration, F is almost always less than 1 due to two main factors: incomplete absorption from the GI tract and the first pass effect. The first pass effect refers to the rapid metabolism of an orally administered drug before it reaches systemic circulation. This metabolism occurs mainly in the liver and, to a lesser extent, in the gut wall. Think of the first pass effect as the body's customs checkpoint. Just as international travelers must pass through customs before entering a country, most orally administered drugs are processed by the liver before entering the rest of the body. Clinically, this means the amount of active drug reaching your patient's bloodstream may be far less than what was swallowed. Let's break down the journey. The first pass effect occurs because of the unique anatomical arrangement of the digestive system's blood supply. Step 1. Intestinal absorption. The drug must first cross the plasma membrane of the enterocytes, intestinal cells. Step 2. Portal circulation. Once absorbed, the drug does not go directly to the heart. Instead, it enters the hepatic portal vein. Step 3. Hepatic processing. The portal vein delivers the drug directly into the liver. Once inside, blood slows in the sinusoids, giving hepatocytes maximum time to interact with the drug. Here, hepatocytes capture, metabolize, and modify drug molecules before the remaining drug escapes through the hepatic vein to reach the heart. Step 4. Systemic entry. Only after passing through the liver does the drug enter the inferior vena cava to reach the systemic circulation. So, what sites are involved in first-pass metabolism? Before exploring each site in detail, consider the following question. Which organ plays the dominant role in metabolizing peptide drugs versus highly lipophilic drugs? A. Stomach, B. Gut wall, and C. Liver. Comment below. Let's resume. While the liver is the primary site, pre-systemic loss can happen in 3 locations. A. The gastric environment, lumen. In this first, acid instability, drugs like penicillin G and erythromycin are unstable in the low pH of the stomach. They are degraded before they reach the absorption membranes. This is why clinicians often prescribe enteric-coated or specially formulated versions of acid labial drugs, which protect the medication from gastric acid and allow it to be absorbed intact in the intestine. Next is proteolysis. Peptide drugs like insulin and calcitonin are broken down by pepsin and pancreatic enzymes, such as trypsin and chymotrypsin, into inactive amino acids. Second location is the intestinal wall, enterocytes. Start with metabolic shield. The gut wall is not just a filter, it is metabolically active. It contains high levels of CYP3A4, the same enzyme found in the liver. Many drug interactions occur when this enzyme is inhibited or induced in the intestinal mucosa. A classic example is grapefruit juice. It contains certain compounds called furanocoumarins. These compounds are very effective inhibitors of the CYP3A4 enzyme in the gut and can elevate blood levels of drugs normally metabolized by this pathway. This can elevate the levels of the medication in your body, leading to serious side effects or even toxicity, even if you took the prescribed amount of the medication, like statins and felodipine. Next is efflux pumps. P-glycoprotein is an ATP-dependent efflux pump. Transporters like P-glycoprotein act as revolving doors, pumping drug molecules back into the lumen after they enter the cell, thereby reducing net absorption. Importantly, CYP3A4 does not work alone. Transport proteins like P-glycoprotein are often found with CYP3A4 in the intestinal lining, and both can act together to limit drug absorption. P-glycoprotein detects drug molecules that have just entered the cell and immediately kicks them back out into the intestinal lumen, while CYP3A4 metabolizes those that remain inside the cell. This cycling increases the time the drug spends inside the enterocyte. This extra time gives the CYP3A4 enzymes more opportunities to catch and metabolize the drug. This synergy creates a powerful barrier that neither the enzyme nor the transporter could achieve on its own. What happens when this double filter is compromised? Let's look at the classic grapefruit juice effect. Compounds in grapefruit juice, specifically furanocoumarins, inhibit both CYP3A4 and P-glycoprotein in the intestinal wall. As a result, much more of the drug is absorbed into the bloodstream. Coming to the most important location, the liver or hepatocytes. Inside the hepatocyte, the liver has one goal: to make this drug water-soluble so the kidneys can flush it out. To do this, it uses a sophisticated two-step assembly line: Phase 1 and Phase 2. Phase 1 is a functionalization phase. Most drugs enter the body as lipophilic, meaning they love fat and can easily slip through cell membranes. That's great for getting into the body, but a nightmare for getting out. In this stage, the liver's master mechanics, the cytochrome P450 enzymes, take over. Using oxidation, reduction, or hydrolysis, they perform a chemical unboxing. They either unmask or attach a functional group, such as a hydroxyl, sulfhydryl, or an amine. We call this creating a chemical handle. Let's look at a simple example of a Phase 1 reaction. A drug molecule, represented as RH, enters the liver. The cytochrome P450 enzyme adds a hydroxyl group to the molecule, so it changes from RH to ROH. This process, called hydroxylation, makes the drug more polar and more water-soluble, helping the body eliminate it. Phase 1 is often a double-edged sword. By modifying the drug, the liver sometimes creates a metabolite that is actually more reactive or even toxic than the original drug. It's also where prodrugs, medications that are inactive when swallowed, finally get switched on and start working. If Phase 1 was the prep, Phase 2 is the packing and shipping phase. This is known as conjugation. Now that we have that chemical handle from Phase 1, the liver grabs a large polar molecule, most commonly glucuronic acid, and snaps it right onto that handle. This process, called glucuronidation, essentially attaches a heavy, water-loving anchor to the drug. Other common ones include sulfuric acid, known as sulfation, and acetic acid, known as acetylation. Let's see a glucuronidation reaction. Drugs with OH groups react with UDP glucuronic acid in the liver. The UGT enzyme attaches glucuronic acid to the drug, forming the drug O-glucuronide. Once a drug is conjugated, it is polarized. It can no longer dissolve in fats or slip back through cell membranes into the bloodstream. It is now trapped in the water pipes of the body. From here, the drug has only two exit ramps. It's either filtered by the kidneys into urine or dumped into the gallbladder to be sent out via bile. Phase 2 is the final eviction notice that ensures the drug actually leaves the building. Let's see how aspirin is metabolized through both Phase 1 and Phase 2 reactions. In Phase 1 reaction, aspirin is broken down by liver enzymes, esterases CYP450 to form salicylic acid and acetic acid. The acetyl group is removed, and salicylic acid now has an OH handle for the next step. In phase 2, glucuronidation, salicylic acid reacts with UDP glucuronic acid via the UGT enzyme to form 1-salicylate glucuronide, a highly water-soluble metabolite that can be excreted in urine. Let's talk about the quantitative side, the extraction ratio, or ER. Imagine you are caring for a patient taking propranolol. You notice that after a dose, only a small fraction of the drug makes it into the bloodstream, even though you gave the right amount. You wonder how much of this medication is actually being removed by the liver before it can act. Clinicians answer this question with the extraction ratio, a practical way to measure how efficiently an organ removes a drug during a single pass through its circulation. This sets the stage for the following formula. The extent to which an organ removes a drug during a single pass is called the extraction ratio. It is calculated as extraction ratio equals the arterial concentration, Ca, minus the venous concentration, Cv, divided by the arterial concentration. If the ER is greater than 0.7, these drugs are cleared as fast as the liver receives them. Their oral bioavailability is very low and sensitive to changes in hepatic blood flow. Examples: lidocaine, propranolol. If ER is less than 0.3, the liver is less efficient at removing these. Their bioavailability is higher and more dependent on enzyme activity than on blood flow. Examples: theophylline, warfarin. And here is the relationship to bioavailability. F. If a drug is completely absorbed from the gut, F equals 1, the systemic bioavailability is bioavailability, F, is equal to 1 minus the hepatic extraction ratio. The first pass effect significantly influences prescribing practices in clinical settings. Now, let's see the clinical implications for dosage and route. First is dose adjustment. Drugs with a high first pass effect require much larger oral doses compared to IV doses. Example: propranolol. For instance, the typical intravenous dose of propranolol for acute arrhythmias may be as low as 1 to 3 milligrams, while an equivalent oral dose needed to achieve similar systemic effects is usually 40 to 80 milligrams. This striking difference is a direct result of extensive first-pass metabolism, which reduces oral bioavailability. Second is route selection. If the first-pass effect is near 100%, the oral route becomes useless. For example, nitroglycerin, given sublingually because it is almost entirely destroyed by the liver if swallowed. Lidocaine, given parenterally because its oral bioavailability is negligible. Third is inter-individual variation. Genetic polymorphisms in cytochrome P450 enzymes can mean that two students may have different first-pass effects for the same drug. For example, let's look into a case study. Consider two patients, Anna and Ben. Both were prescribed oral propranolol for hypertension. Anna has a common variant of the CYP2D6 enzyme and efficiently metabolizes propranolol on its first pass through her liver. Ben, however, carries a genetic polymorphism that makes his CYP2D6 far less active. After taking identical doses by mouth, Anna's plasma propranolol level falls rapidly as the drug is metabolized, while Ben's level rises significantly higher, since his liver cannot clear the drug as efficiently. Clinically, Anna might experience subtherapeutic effects unless her dose is increased, whereas Ben could be at risk for excessive beta blockade and side effects unless his dose is reduced. This variability underscores why understanding a patient's genetic makeup can help personalize drug therapy rather than assume a one-size-fits-all approach. Next is drug-food interactions. Patients should be advised to avoid grapefruit juice when taking certain medications. Grapefruit juice inhibits CYP3A4 in the gut wall, reducing the first-pass effect and potentially resulting in toxic blood levels of drugs such as felodipine or statins. Patient education on this interaction is essential to ensure medication safety. Similarly, some antibiotics, such as tetracycline and doxycycline, can bind to calcium in milk or dairy products. When this happens, the drug forms an insoluble complex in your gut. As a result, less of the drug is absorbed into the bloodstream, which can make the antibiotic less effective at treating the infection. To avoid this problem, it's best to take these antibiotics with water and wait 1 to 2 hours before or after consuming dairy products. Then comes prodrugs. Some drugs are designed to use the first pass effect. A prodrug is inactive when swallowed, but is converted into its active form by liver enzymes during the first pass. Example: enalapril to enalaprilat. This is an example of how first-pass metabolism can work in favor of drug therapy, turning a potential obstacle into a useful activation step. However, this dependence also has a downside. If liver function is significantly impaired, as in severe cirrhosis, the conversion of prodrugs into their active forms can fail, leading to therapeutic failure. For example, codeine relies on hepatic metabolism to morphine. In patients with poor liver function, codeine may provide little or no analgesia. This highlights that first-pass metabolism can be both a friend and a foe, depending on the context. Hence, understanding the first-pass effect is crucial for determining the route of administration. Now, let's check the different methods to bypass first-pass metabolism. To ensure higher potency and lower doses, pharmacists and clinicians use alternative routes that bypass the portal vein. Start with sublingual buccal. Blood drains directly into the superior vena cava. Transdermal. Drug enters systemic capillaries through the skin. Rectal, partial. The lower and middle hemorrhoidal veins bypass the liver, while the upper vein leads to the portal system. Inhalation. This route provides a large surface area and bypasses the liver entirely, resulting in almost immediate systemic levels for drugs such as anesthetic gases or rescue inhalers. Parenteral. Intravenous, intramuscular, and subcutaneous injections. Direct entry into the systemic circuit. At last, intranasal. The nasal mucosa is highly vascularized. Drugs like sumatriptan or naloxone can reach systemic circulation or even cross the blood-brain barrier directly, bypassing the portal system. The next strategy is prodrug design. Instead of giving the active drug directly, scientists sometimes administer an inactive compound called a prodrug. Once it reaches the liver, enzymes convert it into the active therapeutic form. In this situation, the first-pass metabolism actually becomes beneficial. A classic example is codeine, which is converted in the liver into morphine, the compound responsible for pain relief. Another approach is enzyme inhibition, sometimes called the shield strategy. Here, a second drug is given to temporarily block the liver enzymes that would normally metabolize the main drug. This allows more of the primary drug to survive and reach the bloodstream. For example, ritonavir is often used in HIV therapy not only for its own antiviral activity, but also to boost other drugs by inhibiting the enzymes that would normally break them down. Next involves enzyme saturation. Liver enzymes can only process a limited number of drug molecules at a time. If a large number of molecules arrive simultaneously, the enzymes may become overwhelmed. Once they are busy processing the first wave, the remaining molecules can pass into systemic circulation without being metabolized. This is why some drugs show nonlinear pharmacokinetics, where small dose increases can produce large changes in blood concentration. Pharmaceutical scientists also use advanced drug formulation technologies. For example, drugs can be packaged inside liposomes or nanocarriers, which act like protective capsules that shield the drug from enzymatic breakdown. Some highly lipophilic drugs can even be designed to enter the lymphatic system instead of the portal vein. Since lymphatic drainage enters the systemic circulation near the heart, the drug can effectively bypass the liver during the first pass. Finally, there is competitive metabolism. When two drugs compete for the same metabolic enzyme, the metabolism of one or both drugs can slow down. Although this is often considered a drug interaction, in certain clinical situations, it can be used strategically to prolong the therapeutic effect. A classic example involves ritonavir. With other HIV protease inhibitors, competitive inhibition of CYP3A4 by ritonavir can slow the metabolism of co-administered drugs, allowing higher blood levels of these drugs without increasing their doses. Understanding the first-pass effect is vital for safe and effective drug therapy. Always consider route, dosage, genetic factors, and possible interactions when prescribing or administering medication. Thanks for watching. I hope this video helped you understand the first-pass effect and why it's such an important concept in pharmacology. Thanks again for tuning in, and I'll see you in the next video.